Bismillah. Okay, this case, trauma. Proceed, يا boss.
Okay, so I'm presented with axial CT scan of the abdomen and pelvis, including the lower chest, for a patient post-trauma with IV contrast on the portovenous phase. I would like to have a general look before starting my comments. Okay, so I'm not happy about the retroperitoneal region. It shows fat stranding. Yes, there are multiple fractures at the
Good.
region of the pelvis involving both pubic rami with adjacent muscular hematomas. The fractures are
Is a
displaced.
muscular hematoma in which muscle?
Okay, here in the pectineus muscle on the left side.
And obturator externus, and more important, obturator internus, the inner side of the pelvic wall.
Yes.
Okay, good.
Okay, so some of the fracture fragments are displaced, involving the hip joint as well. The urinary bladder seems irregular, with Foley catheter in. However, I couldn't appreciate any active contrast leak within the abdomen or the pelvis. I would like to check the rest of the abdomen, looking for any evidence of free air to suggest any bowel injury, to look for any vascular injury or solid
You are
organ
looking
laceration.
for a free air in this window?
No, in my routine practice, I would change it into the lung window.
Good.
So, yes, there is no liver laceration, subcapsular hematomas, spleen is unremarkable, small amount of free fluid. In my routine practice, I would like to check the density of this fluid to exclude hemoperitoneum. The NG tube in place, the pancreas is unremarkable, the
Can you go
gallbladder
up?
is unremarkable.
Can you go up?
Okay.
Yes. Adrenal.
Okay. Okay, so the right adrenal is bulky.
Good. Yes.
Okay, however, not hyperdense, although
Good.
given the history, I would suggest, I would like to check the density. If it is fat, then it is an incidental adenoma. If it is high density, then I would suggest hemorrhage.
Yes, hematoma,
Okay,
because we have
yes.
also smudging of the fat planes around. Very good. Very good.
Okay, so this is the delayed phase, which is very important in case of trauma to exclude urine injury and urinary leak. In my routine practice, I would like to check for the bone window.
This is the delayed?
Yes.
It's mix between portovenous and delayed. Mix. Okay. How
Okay,
to
so
rule
I would
out?
like to check the bone window. Yes.
Okay. Okay. How to rule out urinary bladder injury in this case? Yes or no?
Okay, no.
Are you sure?
Because the bladder, okay, the bladder is containing contrast with no active contrast leak.
Is this contrast enough?
Okay, so it is a little amount of contrast, so better to check the delayed phase at 5 minutes.
I'll give you.
Post excretion.
Okay. More delayed.
Yes, so there is multiple areas of contrast.
So
yes,
a mix
seen within
between
the bowel, so
portal
it is...
and excretory will not be enough. We need far delayed. Okay.
Okay,
Complete your
so this is
comment.
intraperitoneal urinary bladder injury given the contrast seen between the bowel loops. This is an emergency to be treated surgically by the urology team for further assessment of the bone window, and the sagittal for the spine for further assessment of the chest, and for the lung window there are bilateral subsegmental atelectasis. So you would like to refer this patient and...
Very good. Very good. Very good. So intraperitoneal bladder rupture, since the contrast leakage present in the peritoneal cavity along the parabolic gutters. What is the commonest type of bladder rupture?
intraperitoneal rupture.
Are you sure, يا boss? Are you sure?
I think so.
Okay, no problem. A question for anyone. A question for anyone. Do you agree? Intraperitoneal or extraperitoneal? What's the commonest? You can write in the chat. You can write in the comment. They are disagree, دكتورة نغم. Extraperitoneal. Okay.
Okay.
What is the commonest location or site of injury in case of intraperitoneal bladder rupture? What is the commonest? Excellent, the dome. And about the extraperitoneal, what's the commonest location?
The base.
Good. The neck.
The
Very
region
good.
of the trigone, yes.
Very good for anterolateral wall. So we discussed the incidence and location and signs. Also, please, this is an extra case for you since you are the coordinator. Okay, recommended. Okay, another case of trauma. What do you see?
Okay, so this is a frontal radiograph of the pelvis of a skeletally mature patient. Trauma patient, yes. So there is a urinary bladder in place. I would like to look for any evidence of fracture, which I cannot see. There is no
what
hip
about
joint.
the pubic rami? Pubic rami.
Okay.
Any
So
ill
I think there
definition,
is,
indistinct border?
yes, on the left
Yes.
superior pubic ramus, there is an, yes, a very lucent lesion surrounded by ill definition of the cortex.
Very
It is
good.
representing fracture. So there is no SI joint diastasis as the pelvis is considered as a rim. I would like to look for any other
Very good.
fracture.
Any history that may help you?
Okay, if the patient has fallen on outstretched limbs.
Hematuria or difficult insertion of a catheter. Okay. In addition to trauma, some diastasis also in the left sacroiliac joint. So we perform it. Okay, let's see. This is an enhanced, and this is the enhanced scan. Proceed.
Okay, so this is the CT scan, axial cuts of the same patient with IV contrast. It's showing left bilateral pleural effusion more on the left with associated atelectasis more on the left side. The liver, spleen are unremarkable, no lacerations, no subcapsular hematomas. The heart is unremarkable. The adrenals.
Okay. Every time from now you will look at the adrenal. Okay.
Okay, the pancreas is intact. The vessels are patent. Yes, there is small amount of free fluid at the subhepatic and pericholecystic region.
Good.
The kidneys are, yes, unremarkable bilaterally, no obstruction. The bowel lobes appear
by the way,
unremarkable.
I'm sorry to stop you. In any case of trauma, we should assess the renal enhancement for any shock syndrome and the bowel wall thickening and adrenal enhancement. So in addition to the primary injuries, we have to comment on the presence or absence of shock syndrome. Okay? Complete
Okay.
Down to the pelvis.
So this is, yes, this is the arterial. The IVC is not opacified in this phase. So, however, not slit-like. The pelvis.
I'll give the rest.
Okay,
yes.
So there is a urinary catheter in place, free fluid and air within the pelvis. Again, pelvic bone fractures. This fluid is going up into the lower abdomen. In my routine practice, I would like to check the delayed phase.
Yes, this is very important. Either delayed or the patient now, the vital signs become to drop. Anything that may enhance the study instead of delayed.
Cystogram.
Yes. Okay. We can inject the contrast during early phase even. Okay, what do you see now?
Okay, the contrast is seen in the pelvis, mainly at the base, giving the tooth sign. It is extraperitoneal.
Excellent.
Yes, extraperitoneal bladder injury. In contrast, going down to the.
Good. Regarding the management, how to manage extraperitoneal?
It is usually conservative.
Excellent.
Fully catheter in place for a while, then it will heal.
Very good, my friend. Very good. Excellent, Yavuz. Excellent. Just to revise, we have two types of bladder rupture, intraperitoneal and extraperitoneal. Extraperitoneal by incidence is more common. The location usually at the neck or anterolateral wall. Collection aggregated around the bladder within extraperitoneal spaces or perineum, giving, as you said, my friend, molar tooth sign. This is a pre-contrast and the post-contrast, of course, hypertense due to hematoma, and the management is conservative. Intraperitoneal, less common. The commonest site for rupture is the dome. You will see the collection between bowel lobes within paracolic gutters, and of course, management is surgical repair. Excellent. The organizer, very good. Thank you, Dr. Anar.
Thank you so much.
Welcome. The next candidate.
Assalamu alaikum, sir.
عليكم السلام ورحمة الله وبركاته. How are you, my friend?
Alhamdulillah, sir.
Alhamdulillah. Can
How do
you
you
ask
do?
for control?
Okay. Requested some.
Okay. Before we start the case, my friend, is this breast density normal or you can expect something?
So it seems to be increase in density. So maybe the patient is lactating, mother.
Excellent. Yes. This is a postpartum lady presented with abdominal swelling. You can start.
Okay. So I've been presented with axial CT, post contrast in the portovenous phase, where I can see first. I'll go through all of the images, then I will describe them. So there is moderate amount of free fluid is seen in the abdominopelvic region. And I'm looking at the uterus as patient is a postpartum. So I'm checking the uterus is slight bulky. And I'm trying to just figure out whether there is any signs of perforation or dehiscence, wound dehiscence. I
Good.
cannot see any anterior abdominal scar. So I will just check the pelvic region. So I cannot find any scar in this area to suggest lower segment cesarean section.
Okay, assume there is a close by cesarean section. Okay,
Okay,
so you
so
are looking for any mural defect within the uterus or any area
yeah,
of thinning out, any area of dehiscence. Very good. These two complications that may be responsible for the fluid collection in the abdomen, especially perforation, not dehiscence, because dehiscence is considered a closed perforation. Very good. What else?
okay. Okay, so now I'm going.
What else as a complications you are expecting in the postpartum or post-cesarean?
There is a fluid, air fluid level is seen, which is present anteriorly,
Where?
as the
Where?
bladder is
Where? Where, my
as the
friend?
bladder.
Oh,
This is
yes.
this. You can you see my cursor?
Yes. It's good.
So there is air fluid level is seen anterior to the uterus. So I'm just trying to look or rule
Which
out
may
the presence
represent
of
simply,
bladder.
may represent what? Simply
If
air in the
this
bladder
may
in a postpartum or post-operative.
uh
Catheter. Yes, you
yeah,
see the
catheter,
catheter?
yeah,
Yes.
I
So it's
can
just to
see
catheterize the bladder.
catheter.
So if no great importance. Very good. Very good. What
But
else?
as the patient is catheterized, so there is significant
Mhm.
urinary bladder like filling. So I'm thinking
Mhm.
in line of no malfunctioning of catheter, as
Mhm.
the catheterized urinary bladder usually shows less amount of urinary volume.
Maybe
Okay.
they occluding the catheter for visualization of the bladder. Okay,
Okay.
so
Okay.
no problem, just
Okay.
explanation. Okay, till now, no explanation for the massive amount of fluid, massive
Okay.
amount of
So now
ascites.
I'm looking at the kidneys and ureters to look for the presence of any interventional rupture of the lower urinary ureters. Here I can see that there is a stunt is seen in the right
Good.
ureter.
So you're suspecting maybe urinary tract injury, like ureter or bladder, for example. Very good.
Yeah,
Is this study enough, or you need another study?
yeah. So I can also see that there is a intravenous
Okay,
catheter which is present on the right side, which is extending through the
related to
um,
operative, okay, or related to يعني, to assess the condition and inject fluid, no problem. You can ignore
okay,
this one.
okay.
Hmm. How to
So
assess for a bladder or ureteric injury in this case?
so delayed scan.
Yes, or alternatively, we can empty the
Alternatively,
bladder and re-inject.
yeah, yeah,
Okay, I'll give you,
cystography.
yes. Can you scroll
So,
now? This is a common
okay.
complication, and this is a common quiz.
So here I can see that there is extravasation of the contrast is seen around the urinary bladder
Very
or
good.
anterior to the uterus. And it
Yes,
is here I can see that there is an area of
perfect.
leak is seen posterior at the posterior wall of the posterior inferior wall of the urinary bladder.
And here
So
it
I'm
is the
suspecting.
commonest. This is the commonest location in case of cesarean section. In my routine practice, of course, you will see the sagittal and the coronal. Let me
Yeah.
show you. Let me.
Okay.
Just leave the mouse. Yes. Yes. You see, this is the area facing the uterus. The commonest site for adhesions, anterior uterine wall, and perforation also. The commonest site for bladder rupture in case of postoperative is the posterior wall facing. This is the operative site. Okay, so
Okay.
this fluid can be secondary to perforation of the uterus, secondary to rupture of the bladder, as in this case. It may be also secondary to a significant infection. Okay.
Yeah.
Postpartum endometritis, for example, if we see air inside the uterus or around, and also if we see some enhancement of the peritoneal cavity. Here we have subtle enhancement, maybe just chemical peritonitis because of
Peritonitis. Yeah.
mild thickening. Okay, my friend, I will give you another case.
Thank you.
Welcome. Very easy case. Okay.
Okay. So these are selected ultrasound images of the both kidneys. So I can see that the both kidneys shows normal size, and I'm looking for the presence of any no intraparenchymal echogenic or hypoechoic area within the right kidney. Similarly,
Patient
on
is
the
diabetic.
okay, so I can see that there are few hyperechoic lines are seen
Good.
within the left kidney, and the right kidney appears relatively enlarged and heterogeneous.
Good.
So I'm suspecting emphysematous nephritis in this case, that the patient is diabetic. So I will further evaluate this patient with CT abdomen with contrast to look for the
Yes.
presence of
Urgent. In such
urgent
case,
CT.
of course, in my routine practice, I will comment on the rest of the images. You see,
Yeah.
stone usually, my friends, present in the sinus, not in the parenchyma. And the stone
Parenchyma.
has rounded surface, not linear surface. This echogenic linear surface, it means air foci. And this air foci is scattered within the parenchyma and even outside in the perinephric space. And this will increase the CT staging of this emphysematous pyelonephritis. Thank you, my friend. Thank you.
Thank you, sir.
Well done. Okay, the next candidate.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. How are you, boss?
Fine, Dr. Ismail. How are you?
الحمد لله رب العالمين. الحمد لله. Can you ask for control?
Okay. Request.
Okay. Proceed. No history
I've
given.
been provided. Okay. I've been provided with the non-contrast CT of the abdomen. I'll scroll through the image or start document. Okay. I can see the right kidney show central dense stone associated with multiple gas foci seen within the renal parenchyma. In my routine practice, I will check if there is any associated free air in the retroperitoneal, but it's in lung window.
Good. Actually, the patient has some renal impairment. For this reason, we couldn't give a contrast study. What do you expect the history and lab in this patient?
History, I think this patient may be immunocompromised, maybe diabetic patient.
Yes.
Because there is gases within the right parenchyma of the kidney. the kidney,
Good.
so it raises the possibility of emphysematous pyelonephritis.
Very good, my friend.
Differential.
Yes, differential.
The differential here may be xanthogranulomatous pyelonephritis of obstructing stone, but it will not show any air within the parenchyma. It will be it will show fatty
How
changes
to differentiate air from fat?
on lung window, and I can assess the house field unit. The air
Excellent,
will be
excellent. Yes, the air will be
maybe more than 1,000, and the fat more less than minus 1,000. The fat will be
minus 30,
100.
50, 100.
Yes,
Okay. But air, a couple of hundreds or more than negative or minus 1,000. Okay. I'll give you another case, my friend. Also in the same category. And you tell me if you know CT staging of this case.
I've been provided with a non-contrast study of the abdomen. I can see there is bilateral renal stones, likely to be a staghorn on the left side, and there is bilateral intraparenchymal and extraparenchymal gas loculi within both kidneys, more on the right side. Is seen extending to
And also,
near
okay, in the
right
peripheral.
iliac fossa.
So the
Peripheral.
gas present in the parenchyma and the collecting system and the perinephric and bilateral. Do you know CT staging of this case?
I'm not sure about the staging of emphysematous.
No problem. No problem. It's okay. It's okay. Just give me the mouse. Give me the mouse. What is the expected treatment?
Surgical emergency. Surgical emergency. And empirical antibiotic because the patient may be likely to be immunocompromised.
Yes.
And
If you know, if unilateral emphysematous pyelonephritis and especially advanced stage, it's a nephrectomy. Okay.
oh yes,
If unilateral and advanced, it's a nephrectomy because it's fatal condition. Emphysematous inflammatory conditions usually fatal in this type of patient. Okay, just to revise the staging of emphysematous pyelonephritis, it's related to the location. If gas present in the collecting system only, it will be a class 1 or stage 1. If in the parenchyma, stage 2. If it reaches the perinephric space, stage 3. If bilateral or unilateral in a solitary kidney, whether a native kidney or transplant kidney, it will be stage 4. Usually, if a bilateral disease, fine, for example, 1 or 2 in this stage, or 4 and 4 in this one, nephrectomy will be done. Very good, my friend. I will give
thank you,
you,
boss.
okay, another
Yeah, boss,
easy.
I
Yes.
have one question. And
Okay,
what
boss.
is the main management in this case? They will start the antibiotic
Yes, yes,
like this,
antibiotic.
and
Yes,
see.
strong
Yes.
antibiotic, and usually they will think in or review the need for nephrectomy on the right side.
Mm.
Yes.
Okay. Okay.
Okay, yeah, boss. I'll give you another. To be tricky. Let's see. Not this one. This one.
Okay.
Severe epigastric pain.
I've been provided with post-contrast CT scan of the abdomen in portovenous phase
Again?
in a patient of
Mm.
severe gastric pain. Okay.
Raise your voice.
Yes, I am scrolling through the image before
Yes.
starting
And
to.
by the way, my friends, all of you, some female friends, the voice may be very low. Usually, the examiner will ask you once. Okay, if you keep low your voice, the second time will be aggressive. Take care of this point. Take care of this point. Okay, speak loudly. Okay, my friend, you scrolled 2 times. Okay,
No, I can see the both kidneys are seen intact. The right kidney
good.
show perinephric collection with internal gas loculi.
Good.
I'm looking for the cause of this area. I'm not sure it is connected to the. I can see there is some hyperdense area here. I'm not sure
Yes.
it is related to
Okay,
previous.
you can ignore it, but its
No,
location. Where is the location of this area?
it is anterior to the retroperitoneal. It is seen anterior to the right renal vessels.
Okay, okay. So it's retroperitoneal air. Good.
Retroperitoneal. So I am looking for any retroperitoneal structure which can be ruptured.
Good.
So I will look for the duodenum.
So it's unlikely to represent a condition related to the urinary tract.
Yes, because the kidneys are the right kidney is seen very well
Perfect.
enhanced.
Yes,
No
perfectly well.
intraparenchymal gas,
Yes, very good,
nothing.
very good. So what are the
I couldn't
retroperitoneal structures? You know,
retroperitoneal structure, the second and third part of the duodenum, pancreas also retroperitoneal, also paracolic ascending and descending colons are
so
seen
in this
retroperitoneal.
location, and also
I am
by the way, good, huh?
I'm suspecting the second part of the duodenum. I couldn't
Good.
delineate well the second part of the duodenum.
Excellent.
So and I think I can see there is tracking
Excellent.
here.
You are
It's carrying
suspecting.
raising the possibility of duodenal perforation.
Good. What's the next study, or what do you want to do next in this
I will
patient?
ask this patient, if the patient on the table, I will ask
Yes.
for oral low osmolar oral contrast study.
Excellent.
Okay.
As you wish. Your wishes are orders, ya boss. Okay.
Thank you. I can see there is contrast leak from the second part of the duodenum to the area of interest.
Yes.
So it is rupture duodenal.
Show me the site of rupture or ulceration. Yes, yes.
Here is
So
the
this
same place.
hyperdense focus may represent actually a food particle that
Food particles,
yes, extravasated or extraluminal through this defect.
So
Excellent,
it is
my
a
friend.
surgical
Yes.
emergency. I will urgent refer the patient to gastroenterology
Yes.
surgical team for fixation of the
Gastroenterology.
duodenal
Good. Gastroenterology.
gastroenterology for
Not urology. Very good, my friend. So just to
okay,
revise, if you see any air within the retroperitoneum, it may be infectious process or it may be perforated viscous. Infectious process usually arising from the kidney, like abscess, nephric abscess, for example, or perforated viscous, like duodenal perforation or ulceration, or ascending colon in case of trauma, malignancy, whatever. And sometimes related to perforated subhepatic appendicitis as well. It can lead to an abscess in this location. Excellent, my friend. Excellent, excellent.
Thank you. Thank
Okay.
you, Ismail.
Welcome. The third candidate.
Yes, sir.
How are you, يا boss?
السلام عليكم ازي
Just
حضرتك؟
عليكم السلام ورحمة الله. Just leave the mouse, my friend. Leave the mouse. Leave the mouse. Okay. Okay. I will take the control. عليكم السلام ورحمة الله. Okay. I'll give you. Can you ask for control?
Yes, sir. Okay. Requested.
Okay. And give him. Okay.
Okay.
Raise the inflammatory markers with some renal impairment. What do you see?
Okay. I'm provided with axial CT images of abdomen and pelvis, contrast enhanced. Okay. Sport to venous phase.
Good.
Okay. Okay. I'll have a moment scrolling through the images before giving my comment.
Okay.
Okay. Okay, the striking abnormality is the presence of air foci at the site of the right kidney. Okay, I'm looking.
And
Okay, it's jumping. Uh, at the right kidney and
what about
seen,
the appearance of the right kidney? You see some air foci
and there's some atrophy and there's surrounding fat
good.
stranding could be identified.
Just
Also,
go,
there is
go up,
foci.
go up. What about the appearance of the kidney?
There is also the dilatation of the pelvic calyceal system, moderate dilatation, and the air is seen extending into the left pelvis, in the right pelvis.
So this is the
Okay.
pelvis
Mm,
or fluid collection within the parenchyma?
yes, yes. Yeah, it's a fluid collection, and there's surrounding fat stranding.
Good.
Okay, and there's also this this collection is extending into the posterior
Good.
pararenal space, and also it's extending to. I'm trying to delineate the right source also to see if there's
Very good.
extension to the right
Very good.
source.
Very good.
I think it's also involved. This there's collection within it.
Good. Good.
So
Till now, what are the findings or what's your diagnosis till now?
so there is extensive enzymatous inflammatory
Good.
process affecting the right kidney with the perirenal and right source collection. There's also
Enhancing
hypoenhancement
collection. So
of,
it's abscess. Abscess.
yeah,
Good. Good. On top of, you said atrophy of the kidney,
yes.
but the
Uh,
appearance of the kidney doesn't guide us to a certain diagnosis.
I'm looking. I feel that there is a pelvic calyceal dilatation also, but
Okay.
I'm
Okay. Okay. No problem. No problem.
yeah.
Downwards, there is something else.
Okay, I'm trying to also see if there's extension to the ureters.
Yes. What is this dense structure in the ureter?
Yeah, okay. There's a stone here.
But
It's
very
seen.
long. It's very long.
Yeah,
History of neglected catheter.
yeah.
So
Neglected catheter.
yes,
So
it's
there is infection on top of.
yes,
It's
it's a
infection. Of,
calcification around ureteric catheter, also present in the urinary bladder. It's a calcified ureteric catheter. And of course, this is urological emergency. I need to. What's your management?
okay, I think it's a surgical emergency. I'd like to refer it urgently to the urosurgery for nephrectomy,
Yes.
right side nephrectomy, and also drainage of the surrounding collection.
Interventional radiology, either drainage or urosurgery, nephrectomy directly. And this is the best way for treatment. But what about the appearance? Huh? Collections within the parenchyma. Does it
Yes.
alarm anything if you have a stone or a calcified structure and
Yeah.
long-standing, the parenchyma is expanded, but it contains collections?
Xanthogranulums.
Yes, yes.
Yes,
Okay.
xanthogranulums.
Okay, okay.
There's
I'll give you another
oh,
case.
okay.
Just give me the mouse.
Okay.
This is a calcified, Bismillah, calcified ureteric catheter. It mimics a stone in the urinary bladder and also here along its course. Okay.
Okay, here I'm provided with XCT images, contrast enhanced. What is the history of the patient?
No given history.
Okay. Uh,
Okay, renal event.
renal impairment. Okay, I'm scrolling through the images before giving my comment. It's arterial phase actually.
Yes.
Okay, there is some areas of hypo enhancement seen occupying most of the right lobe of the liver.
Right loop of the liver.
Yes, I'm
You
looking.
forget the most important and basic rule. In my routine practice, I check from the first till the last cut.
Yes, yes.
Because where is the kidney? Okay.
Yeah.
Where is the right kidney?
Okay, The images are jumping.
No problem.
Okay.
But is it right renal pathology or hepatic?
I'm looking. Okay, it's actually right renal. Yes,
Okay.
right
Okay.
renal pathology. There is
I'll give you a better phase. I think the portal maybe just give me the mouse. Give me the mouse.
okay.
Okay. Okay. It's just adjacent to the liver. But what is the abnormality?
The normality here is okay. There's the right renal parenchyma seen having well-defined collection, and also there is replacement of the parenchyma with fat attenuation, I think, with pelvic calyceal branching stone, consistent with staghorn stone, and
Excellent.
on top there is right xanthogranulomatous pyelonephritis with
Yes.
the
Yes.
surrounding fat stranding.
Very good, my friend. Very good. Very good. You see, my friends, this is the nature of the name, Zansu. It's lipid proliferation, okay, or infiltration of the renal, especially renal sinus and sometimes renal parenchyma. You see, this is the Zansu. This is a fat infiltration. Very good, my friend. Very good. It's a typical case also. Also, yes, we have also here an abscess and perinephric abscess and
Yeah.
psoas abscess. The same as the previous case.
Yes.
Okay, good, my friend. Just give me the mouse. Give me the mouse. Yes.
Yeah.
Okay. Well done. Well done. Okay,
Thank
my
you.
friends, it's another type of inflammatory or infectious inflammatory process of the kidney, where there is an obstructive lesion, usually stone, like staghorn stone, giving the classic appearance, which my friend didn't say anything about, which is called Pierce-Bow sign. Pierce-Bow sign. Fluid collections within the renal parenchyma and residual atrophic enhancing parenchyma in between. In addition to this fatty infiltration of the kidney. So it's xanthogranulomatous pyelonephritis. Very good, my friend. Excellent, excellent. Okay, I think we finished this case also. Just stop record.